Good evening, everyone. A warm welcome to day 15 of SICON, the world's leading career conference for aspiring pharmacy professionals. I hope you all are as excited as I am for another insightful evening filled with learning, inspiration, and practical knowledge. Today, we have an exceptional lineup of speakers who bring with them global expertise, academic excellence, and real world clinical experience. Let's take a moment to acknowledge and welcome our distinguished guest, Dr. Akhil Arun, PharmD, MBA, JCSRT, Harvard Medical School, USA, Dr. S.P. Srinivas Nayak, PharmD, MSc, PhD, Assistant Professor, Pari University, Gujarat, Dr. S. Manoj Kumar, PharmD, Medical Director, Dr. Manoj Medication Opinion Center, Private Limited, Tamil Nadu. Let's go through the agenda for this evening. Our first session will be on RX for older adult geriatric clinical pharmacy A to Z by Dr. Akhil Arun, covering comprehensive approaches for geriatric care. Second session will be on clinical case discussion optimizing geriatric pharmacotherapy with Dr. S.P. Srinivas Nayak, a practical case based learning session. And the third session will be on Medication Opinion Center, Vision, Mission, and Patient Centric Impact by Dr. S. Manoj Kumar, exploring innovative, patient focused care models. So sit back, take notes, and engage actively because today is all about expanding our understanding and skills in geriatric clinical pharmacy while getting inspired by leaders in our field. Let's begin with our first session, and to start us off, please join me in welcoming Dr. Akhil Arun. Akhil Arun, sir, is the spirit of academic excellence and global impact. A PharmD Gold Medalist, MBA in Healthcare Administration and Hospital Management, and a Global Clinical Research Scholar from Harvard Medical School, Dr. Akhil Arun has consistently pushed the boundaries of healthcare innovation. Currently serving as a lecturer at the Amrita School of Pharmacy, Dr. Arun has guided numerous postgraduate and graduate research projects and contributed extensively to pharmacotherapy, pharmacoepidemiology, and clinical pharmacy education. His research spans from advanced pharmacogenomics to public health, with multiple international publication and conference presentation to his credit. As a host and producer of RX Pill podcast, he has created a platform that bridges clinical expertise with accessible healthcare communication. He also has contributed to global networks like Cochrane and the Pharmacogenomics Global Research Network. Dr. Arun's work has earned him prestigious honor, including the DST Inspire Fellowship, the PharmD Gold Medal from Rajiv Gandhi University of Health Sciences, and international recognition for his research on psychiatric pharmacogenomics testing. With a career dedicated to evidence based practice, patient centered care, and healthcare innovation, Dr. Arun is here to share insights that promise to inspire us and enlighten us all. Please join me in welcoming Dr. Akhil Arun, sir. Welcome, sir. The stage is all yours.
Thank you so much for such a wonderful introduction. Too much to say and a lot of description. Thank you so much. It's a wonderful day ahead. And at the outset, I'd like to wish all of you a very happy Independence Day today. We are celebrating our 79th independence here in India. And saying about that, independence, or definitely what we say, freedom, comes with a lot of responsibilities. And we here are professionals who work day and night. That is, we come from the healthcare background and we have a very huge responsibility that is shouldered onto our head to take care of people who are ill or who are not well or who are unwell. And we have to essentially make their lives better. Now, for today's session, I am very grateful to be given this opportunity from the entire team of RX doctors, led by the dynamic Dr. Jain and the entire team. And also, while we delve into today's session, I'd like to make it a little interactive with often quizzes or small polls just to get to know where are we at right now. So right before I start, I'd just like to share my screen if you could confirm whether everything is clearly visible.
Your
I
screen
hope.
is not visible, sir. Okay, now it is.
Can
Now
you
it is.
I'm going to just switch it on to a full display mode. It's clear? All good?
Yes, sir, your screen is visible.
Yeah, great. So the topic that's given to me today is talking all about basically drugs or medicines for older adults. Now we are covering from the geriatric perspective of it very specifically. Now starting from the basic, that is from A to Z. So you're taking the very basic intricacies of how we treat a patient to the very advanced setup, or what would we want, or what do you see in the near future of this particular field. Now, already my introduction is made, so I would not like to take much more time on this, but let's talk about why essentially geriatrics is really that important, or why do we need it? So before I step into this conversation or this exchange of information that would happen, I'd like to cite or begin by citing a small quote. This was a quote that was very specifically given by World Health Organization. Now, what does it read? It says, the goal of medicine for elderly is not just to add years to life, but rather life to years. Now, this is in core a very important statement that medicine has to be more holistic. Now, people, if you talk about, we all have people in our home who are at this geriatric phase where maybe our grandparents, could be our elders, or they take any form of intervention as a matter of fact to just extend their life. That is, they just live a little longer. So I have extended his or her life by giving him that particular medicine, or by, let's say, with hypertension, I gave them medicine. So this person's hypertension is controlled. Now, at the same hand, there is another person who's got maybe a lot of lipid buildup in his body. I gave them statin, and his lipid profiles are significantly normal. But we have managed to somehow increase their lifespan. But what about that life that they are living? That is where the concept of what we call as quality of life walks in. So I'm not just adding life to years. I'm also, so basically, I'm not just adding years to life. That is, I'm not just increasing or prolonging their lifespan, but I'm rather trying to do, what I'm trying to do is I'm trying to give life to those years. That is, although he might live for, let's say, another 1 decade or maybe another 5 years, these 5 years should be the best 5 years of his life, and I'm extending it, or I want it to be better than with the disease existing, and at the same time, with disease existing and the medication, the patient feels much more better. Now, welcome to the entire session that I'm going to start. Just to get a quick review on what is your opinion about, or what do you feel about how many medicines on an average does an elderly person take? Now, I'd like you guys to just step it in and enter it in your chats. What's the average you think? It's from one to two, 3 to 5, 6 to 8, or 9 or more. What's the average that you would think a person would take? Um, so I hope there are some answers. I believe if someone can just unmute their mic and let me know what's your answer to it. What do you think would be the average of the medicine, or the number of medicines that one would take? You just have to make a random guess. You don't have to worry. Your answers might be
So
correct or might
there are
not be
few
correct.
answers. Many of them are answering 3 to 5, and
Okay.
I can see a bit of 6 to 8 as well.
Okay. So the
Uh,
majority lies in
sir,
5.
depends on I have seen for diabetes and hypertension taking 7 to 10 daily doses.
Yes, fair enough. And so I assume that most of you have been around the value of 3 to 5. Now, just to give you some shocking, now this is from a global perspective that I'm discussing now. Just to give you a shocking discovery, a recent survey that was done by AGS said that, that is American Geriatric Society, they said that people on an average, the elderly people take close to 6 to 8 drugs per day. Now, that's a huge amount of drug considering a single person. So that's where really me and you as healthcare professionals walk in. okay, and we contribute, or where our presence is really required. Now I'd like to delve closely towards the main agenda of today's session, okay? Now, why exactly do I need to talk about healthcare, particularly in elderly, or what's the reason to it? Now, you see, we say that there are a lot of young people around us, but at the same time, the fastest growing age group that is worldwide is actually people who are of the geriatric population or people who are elderly. Now, what happens when you're elderly? You're going to have frequent healthcare visits. More frequently, you're going to have hospitalization. Medications are much more higher in these patients, very particularly when we compare that to the other demographic, or maybe the late young adults, or maybe the later young people. Okay. Now, also when we talk about these many things, that you're going to have multiple healthcare visits, frequent hospitalization, and even medications per se, what we see is a huge economic burden that's going to be laid on maybe the entire economy globally, as well as even within the countries all around the globe. Now, why else do you think, why else would I talk about catering to the needs of the elderly? One major risk that they have is adverse drug events. That is nearly twice more likely to develop the adverse drug reaction or hospitalizations due to an adverse drug reaction. Okay. Now, this is the area, or this is where the niche area of geriatric clinical pharmacy walks in. That is, you're trying to provide a safer alternative or a safer, more rational therapy to the patient. Now, if you see, what's the difference between an average person or someone who's a young adult versus someone who is an elderly? You see, they have three times more medication. So it's pretty much clear that around three times higher. Maybe we might take a paracetamol or some medicine once in a while, but someone who's an elderly would have to take multiples throughout the day. Now, 17% experience adverse drug reactions, and 28% have hospitalizations that are medication related. So it's actually a very concerning environment or very concerning area to begin with. Now, what's the key challenge out of all of this is the mortality. That is, adverse drug reactions that are significantly seen as the leading cause of mortality in elderly, the fourth leading cause. Now, this in itself creates a mindset, or this in itself gives us a open platform for people like us who are trained in the field of clinical pharmacy to contribute. Now, what do I assume that you would learn, or I'll try my best to achieve these goals by the end of the sessions? That is, by the end of the session, I believe you'd be able to do a couple of these steps correctly, or at least you'd be able to understand, or you'd be able to achieve these goals by the end of this presentation. Okay, so basically, we're going to start by building up some knowledge, some practice, and how that practice would impact the later decisions that you make. Okay. So you're going to recognize what are the challenges that you might observe in someone, or as a person who might work with geriatric pharmacotherapy. We're going to go into a little bit of the basics, that is your pharmacodynamics, pharmacokinetics, and how does that exactly change the entire drug response of the person. Now, very important, we have already seen that a person who is a geriatric patient is going to take anywhere between 6 to 8 drugs. Now, you need to know which of these drugs are of the highest potency to cause problems to the patient. Now, I've identified what is the, basically, I've recognized what are the challenges. I have understood how does that work at a molecular level. And now I've started taking the drugs, or identify what are the key culprits. The next thing is how to find a resolution to it. So I'm going to start, or we're going to go a little bit more deeper into how to safely, or how to maybe take up safe prescribing tools, and how to safely administer that, and how well we can allocate the resources that are given to us in form of drugs. Then at the end, we're going to talk as how we can contribute, and what might be expected, or what we might want to work towards in the near future. Now, let's talk about the global aging trend. This is quite drastic. Let's see. By 2050, 1 in 6 people worldwide would be over 65 years old. So most of the people, you see, 1 in 6 is a huge number pertaining to the number of people that is globally. Okay, so 1 in every 6 would be people who are of 65 and above. And by 2030, what is assumed is that elderly would outnumber the number of children under the age of 10. This would happen for the first time in the history. Usually, children below the age of 10 are higher than the elderly, but this is going to be the first time it would happen in the history. And that is a prediction that's made basically using Delphi softwares. Now, coming very specifically to India, you see the trajectory that is expected. So by 2021, the elderly were somewhere around 140 million. Now, coming to 2050, maybe another 30 years down the line, what we expect is 320 million. That's almost more than double of what we see right now. Okay. Now, healthcare system might have problem with this shift. Why exactly? We have already discussed giving a single drug is costly, is costing something or some amount to the entire healthcare fraternity or maybe to the entire, let's say, the healthcare system. Now, think of it, if the same pattern continues, what would you see in the near future is a unprecedented challenge. So if it's not calculated well and you do not start to plan accordingly, the problem is going to be that this unprecedented change that you see in the demography is also going to cost a lot to every economy or maybe even globally. So resources are limited, and I need to allocate the resources in the right senses so that I can help the people around me. Now, talking about the regional areas or areas particularly where we have higher healthcare needs pertaining to elderly. The very common example that I believe most of you would know is with Japan. The population of elderly is much more higher, whereas the youth is declining. Similarly, in Europe, you have close to 25%. They expect that 25% over the age of 65 by 2030. Again, 400 million elderly by 2040 within China, and within USA, all baby boomers over 65 would be around that age, would be over 65 by 2030. Now you see the inclinations. So the trajectory is basically going from a baseline to a very high number. Now this is where, if the resources are already limited, and if I do not plan it correctly, and if I do not optimize the safety of these people whose numbers are increasing gradually or at a very fast trajectory, I might be at a position where I might be at risk of not being able to deliver, and at the same time posing a huge amount of problem to people around me, because resources for every economy are very limited, but I have to plan it in such a way that resources are not exhausted and I make the most of it. Now, why focus about them very particularly? As we have already discussed, they take 3 times more drug than younger adults. So, fourth leading cause. The major thing that we have discussed just now, as most of you guessed, that somewhere around 6 to 8 or 3 to 5 is a huge number, that is polypharmacy. Now, what does it do? Leads to confusion, often, correct? People, increased risk of fall is closely associated with your use of multiple drugs, and eventually this falls leads to hospitalization. Now, medication does not come for free. Even if you go to a government hospital, you might procure a medicine or you might be able to receive a medicine. The basic entity is that the government has to plan or allocate certain amount of the fund that they receive from the entire economy to treating people or for healthcare benefits. Now, this is going to be a lot of burden. Talk about 6 to 8 drugs. It's going to be a significant amount for the person to pay for, or even for the government to look for it. That is where the challenge per se walks in. Again, what's the critical need right now? Specialized, this is a basic assimilation of certain studies. What they have shown is that with appropriate clinical pharmacy services, excuse me, what we can hope is that in the reduction can be seen in the adverse drug events up to 35%. Now, let's say from 100, even if it's dropping down to 35, that's a huge benefit. So you have lesser amount of money spent towards treating it, and much more amount of money saved that could be used for something better. Now, if you see, medication related costs within US itself is a huge number, that is close to 528 billion US dollars. Now, we know that pharma is such a huge contributor worldwide, and again, within that itself, pharma induced problems are also contributors, if you can see very clearly. Now, what do I see, or what makes it challenging for people around me to be, or for people around me or people like us to treat geriatric patients. Polypharmacy, we have already discussed the ranges. So people anywhere greater than 5 medications would have increased risk of interactions and further drug adverse events or drug events. Comorbidities. So when one of you said that the number of people with more number of comorbidities increases the number of risk and more complex regimen is required to treat them. Just as one of our fellow a few minutes back just said and talked about diabetes, hypertension, and many more. So everything together, if you see, is actually going to be difficult to treat. One drug is treating a disease, and you do not know whether that one drug could induce another disease. Okay. Now, cognitive decline. So you know that people, you want them to be safe, but at the same time, you also know that these are people who have decreased cognition, or they do not have the same memory capacity that a 30-year-old might have, or maybe a 20-year-old might have. So they might miss on doses, take up the wrong administration, confuse with medication changes. Anything can happen. I'll just give you an example. Okay, so there was this patient that I met during my internship. So this patient, he just identified his medicine using the color of the tablet. Okay. And the next time when he walked into the OP, doctor had prescribed to him a similar tablet, but a similar looking tablet. But what happened? It was at a different time interval. Now, this person was not given the right kind of information or the right kind of counseling to take this medicine, that this drug A at this time and drug B at that time, maybe at the prescribed time. So what he did, he took only one medicine, thinking that the other new one was the drug A, that is the new drug B was the drug A. So he was only taking one medicine and missing out on the second one. Now, what happens a week, 2 week back when he visits the OP, his BP is still shooting high. It's not coming down, and he is worried and he started to feel lethargic. He's confused. And when the prescription was cross-checked and when the doctor asked them to confirm what and all did you take, then they realized that the person, this particular patient, was only taking one medicine instead of two, just because these two looked similar. So you see, they confuse very often. Now, this is a serious problem. Again, sensory impairment. Some of them cannot hear. Some of them have difficulty with vision, or some of them cannot even walk. Again, many times, one more important thing is the financial burden that comes with procuring a drug or maybe getting a new drug. So the cost is very high. Cost constraint in itself can cause a lot of problem. Next, you have inadequate support. So many times we see that people end up being in old age home or maybe end of life care. What happens is there is very limited assistance that one can give to them. And that also poses a major challenge. So basically what you see towards the right hand side, this figure is just going to give you a brief idea of how these components interplay together to increase the risk of medication. Now, coming to the pharmacokinetic changes or changes within the body that you might see in a person. Absorption is usually unchanged, is what we claim, and the significance is very minimal because physiologically something has changed. You cannot really improve it to a greater extent. So your gastric acid production goes down. Your gastric intestinal motility, basically a peristalsis or how the movement happens, the gastric movement is also going to go down. Again, the transport mechanism. So you want to and fro exchange of things, that is going to change. Coming towards the A, we have discussed the A, that's absorption. D, that is distribution. Basically, you see that people who are of the older age have higher body fat. Now, this body fat is actually a living haven for lipophilic drugs. Now, they get easily lipophilized with this media, and what happens is you have longer action. On the other end, you also see that there is decrease in the total body water. Now, what does this do? What it does indeed is it's going to increase the level of hydrophilic drugs. Now, with this, you see the drugs that are mentioned here, digoxin, lithium. You know that most of these drugs are the drugs that are actually subjected to tedium, because you see the slightest amount of elevation to this drug levels in the body would cause n number of challenges to the patient and for the treatment. Now, metabolism, you see, we know that with older age, metabolism is going to slow down. And with that, the hepatic blood flow is going to go down, liver mass is going to be disrupted. your enzymes are also going to change. This is a very niche area to work on for research, because you find many new SNPs that can be used to treat or maybe individualize the therapy very particular. Now we see excretion. You know that most of your excretion happens through your kidney. Now this is said that with every year, or after the age of 40, every year that you're gonna survive, your glomerular filtration rate is gonna go 1% lower. Now, what does that mean? That means even before you're reaching your geriatric age, your kidney functions are already declining. Now, that is very necessary to talk about high risk medicine and how exactly I'm going to be using it. So, NSAIDs, your aminoglycosides, we know very well, metformin, digoxin, all of your direct or direct oral acting anticoagulant drugs, all of these drugs are going to be very uh, particularly involved in making the entire panel very difficult to be, or making the entire patient very difficult to be treated.
Excuse me,
Coming
sir.
to,
I'm so sorry to disturb you. Your slides are actually not visible.
is it visible now?
We can only see the first slide.
Now also?
Yes. Okay, now it is visible, sir.
Also, so you were not able to see the past few slides when I changed them?
No, no.
Okay, so now is it visible? It's better?
Yeah, it's better now.
Yeah, yeah. Thank you. So the pharmacodynamic changes is something that I'm going to discuss now. That is how exactly the shift happens. So sensitivity to certain drugs are going to increase. CNS drugs, it's going to increase. And again, sensitivity to some form of anticoagulants are also going to increase. But to the contrary, what you would also observe is decreased response to a lot of drugs. What we see here is a decreased response to your beta blockers, increased risk, all of this together, this fair interplay of these drugs together, what it would do is it would also increase the risk of ADR. Now, what do we need to do? Standard doses may be inappropriate and potentially harmful for these patients, because you see the sensitivity of certain drugs are higher. So they are much more sensitive to certain drugs. On the other end, certain drugs have decreased response. So if I give them the ideal doses, they are going to end up in trouble. Now, this is where the epidemic of polypharmacy walks in. So as we've already discussed, basically polypharmacy is nothing but you have drugs that are more than 5, or you're taking more than 4 medications simultaneously, very commonly seen in elderly patients. Now, there is this effect that we see very commonly. This is called as a triple whammy effect. Okay. Now, this effect was indeed seen in a lot of patients. You see, this combination in itself, if you can see that very clearly, NSAIDs, diuretics, and ACE inhibitors. These are a couple of drugs that are very frequently used within the geriatric care, because you might need an NSAID, you might definitely need a diuretic, and most of the patients are anyways hypertensive. So club these together. What was observed was that people who are taking these three drugs simultaneously, you will see that they had a very increased risk of kidney failure. That was acute kidney injury was much more higher. The risk was as high as 30%. So this is very commonly seen in patients who are hypertensive, in some form of pain, or have heart failure. So you're going to obviously prescribe these drugs. Now, this is where the entire problem of polypharmacy walks in. That is, one drug at a time. You're gradually taking multiple drugs, and just this three combination, you tried to cure something, you ended up with something else. Now, this is just a brief summary of a couple of drugs, a couple of things that you might see. I'm just going to go with brief. Very important are things that you would see with geriatric syndromes, things that you would commonly observe. The first thing that you would observe is falls. Falls are relatively very high in someone who's who's of the geriatric population. Again, when we talk about delirium or confusion, is another thing that's very common. Most the falls as well as delirium are most commonly attributed to the class of anticholinergic, basically. And then you have constipation, which is again a problem. And you see over time your bladder control goes, so you have urinary incontinence and frailty. Basically, you're weak. So these drugs, all of this appetite suppressants, your anticholinergics again, your high anti-catabolic drugs, corticosteroids, sedatives, all of these are a major contributors basically to making you more weaker. So these are a set of syndromes that you might see. That is falls. Commonly, people fall very often, and that leads to fractures, and that's again a hospitalization increase. You have delirium, that is, people frequently have confusions. Constipation is again another common. Again, this is all constipation. We know that the peristalsis or the movement across the GI motility is going to go down. Control over your muscles are also going to go down rapidly. And again, frailty, weakness is also going to come. So all of these things are couple of things that you will see very frequently with when you're treating someone who have geriatric age group. Now, to treat this exactly, what can be done? This is where AGS or American Geriatric Society walks in with a very important criteria that we call as Beers criteria. Okay, it was first started in 1991, and you have the updated version that follows. What does it basically do? It's going to give you indication of what is or what are the potentially inappropriate medications pertaining to someone who is of older age. And why do you use it? The first thing is that it's evidence based. So it's in par with the latest research. Next, guides safer prescribing decisions. So you know that there is a standard to match to, certain things to be removed, certain things to be added. Risk reduction, the reduction of ADRs or the number of ADRs can be reduced. And the latest one that you have is the AGS Beers criteria 2023, very commonly used. Now, just remember a couple of drugs that I'm going to discuss now. You might have to apply it in the later half when we take some clinical cases, to answer these questions. The first one is an example. The first example that you would see are long-acting benzodiazepines. These are potentially inappropriate medications, or what we call as PMIs, PIMs. I'm sorry, diazepam, chlordiazepoxide. What you see with them is risk of prolonged sedation or falls are much more higher. Anticholinergic, diphenhydramine, your tricyclic antidepressant, are going to cause urinary retention, or per se, it's also going to cause confusion. NSAIDs, increased risk of GI bleed, we know, and again, renal impairment that we have discussed previously with the triple whammy effect. Glyburide is another drug that leads to prolonged hypoglycemia, which could be fatal to the patient. The patient might end up in serious consequences. What do we know about, or what is something that is to be remembered? Okay, Beers criteria is a guideline, but it's not an absolute contradiction. That is, you can use it, but then your clinical judgment of that particular treatment also plays a very vital role. So basically, you're not going to just use it randomly. You just say that, okay, Beers criteria states so, so I'm going to just use it and just remove whatever is present, or add whatever is necessary. That doesn't work like that. So you have to take clinical judgment or make a strong decision as to why should I remove it if I remove it, or why should I add something else if I add it. Now, coming to the second criteria that's most commonly seen, and you might all know, that is called the stop and the start guideline. This is another way of potentially finding out PIMs, and also potentially prescribing omissions can be prevented in patients. Okay, so what is stop? Screening tool of older people's prescription. So what it does, it basically identifies medications that can be stopped. Let's say NSAIDs. Where do you stop it? Heart failure, peptic ulcer, if they have a EGFR of greater than less than 50. Benzodiazepines, you know that someone has a history of falls, I'm going to remove that drug. Anticholinergic, dementia or someone with glaucoma has to be removed with such kind of drug. PPI, max dose for greater than 8 weeks. Now, again, comes towards the start. Identifies what beneficial medications are missing, what can be added. So this is a little bit more descriptive. Now, examples with this is diabetes, and you suspect someone with nephropathy. So what you do is ACE inhibitors or ARB can be started. Chronic atrial fibrillation, you can start someone with anticoagulants. You know someone is of osteoporosis risk, you start them on vitamin D and calcium. And again, you can start if someone you know is of COPD or any other problem, you can start them on inhaled corticosteroid. Now, all of this would actually reduce the risk in the patient. Again, what you can do, there is this common thing that we do that's called de-prescribing. So what was prescribed, essentially you take that out by making we all know that we come from this principle that's called a risk versus benefit. So basically we are talking about a scale where what's the risk And does the risk really have benefits? That kind of weight would constantly remain. So you have to balance the two, risk and benefits. So it's always said that risks should always outweigh the benefits. The benefits should be higher and risks should be lower. Now, this process is where we remove certain drugs from the elderly or based on seeing potential benefits and then coming out to a conclusion whether I can remove it or not. Deprescribing intervention can successfully discontinue 1 to 2 medicine per patient on an average. Now, this is again with a lot of planning. So, who is involved? You have three people who are involved here: the physician, the pharmacist, and at the end, the patient. The physician checks the entire diagnostic pattern, all of those things. Then pharmacist contributes to making the right drug choices and maybe suggests this can be removed. And then patient says that I prefer this over that, and accordingly I do it. How do I do it? I make a review, medication review. Then I identify what is inappropriate, gradually taper and monitor. So it's not that someone is on a medicine, I strike it off right away. I might have to gradually taper it down and then remove it. And after removal or after tapering it down, you have to do a follow-up to check whether he's really improving or not. Now, why do we need a clinical pharmacist to do all of this? Clinical pharmacist could be the best person to talk about reconciliation or reconciliation of your medication. Dose adjustment can be very well made by a clinical pharmacist. Counseling, which is most required, just as I discussed the case before, the two drugs or the two tablets look very similar. So what they did, I remove one, I take one. They look similar, so they might be similar. That is what the patient assumed, and that led to his BP skyrocketing. And obviously, a clinical pharmacist always monitors for ADAs and interactions. And with that, he's going to be able to contribute in ways in which it can essentially uh, use his knowledge, the physician, or the entire team together. So basically, we join hand in hands. We do not function as individual entities. So this is where the concept of interdisciplinary collaboration comes in. So someone as a physician tells certain thing, the nurse administers it, and the nurse provides the care. Then pharmacist walks in and he or she maybe helps with the correct drug choices. And then also at the later half, you have some psychologists who provide mental support to this patients because they're also, most of them are also patients who are depressed. So this is a major concern. So you see the entire holistic approach. So I'm forming a large circle by joining hands. So basically I'm facilitating what we call as interdisciplinary collaboration. And with this, what happens? Your average cost, that is close to 1200, close to 1200 US dollars is saved. This is what they say: decrease in hospital readmission, fewer ADAs, and at the end, improvement in medication adherence. Now let's take a small look at this case. Okay, so there is this patient profile of someone who's a 75-year-old male. He's got hypertension, he's got type 2 diabetes, and he's also a patient who complains of insomnia. Okay, he has got a renal failure that we see very clearly with the EGFR value, that is 45 ml per minute. It's decreased. Living situation, he is independent but lives with a spouse. Okay, that is independent house, but with a spouse he lives. What are the drugs that are given here? The drugs that we have given here, this is just a case that was seen, and I'm just going to explain it to you, and then we'll have a question later on. You see, the medication that was given was atenolol. We know that it is given for hypertension. Metformin, twice daily, given for diabetes. Diclofenac is also given 3 times a day for arthritis pain. Diazepam is again given at bedtime, 5 mg, for insomnia. Omeprazole is also given for gastric prophylaxis. Now, what could be the problem? The first problem with this therapy that was identified while I was going through this chart was atenolol is generally seen to be not very effective in elderly. So increased risk of bradycardia would persist. Okay. Diclofenac is a culprit drug. You're giving it 3 times a day. So the risk is going to be much more higher. And that with the GI risk of bleed is much more higher. And at the same time, we also know it's a drug that is also going to cause changes in the renal function. So already the patient is compromised renally. Again, with this, it's further compromised. Another thing that we see from Beer's criteria, if you remember, we talked about long-acting benzodiazepines are closely associated with risk of falls and also excessive sedation. So someone who might want to drive if they take long-acting diazepam at bedtime, and if there is a residual sleep problem, that could also be a significant concern. Omeprazole in long term is associated with fracture risk. And you see fracture and falls together with the risk of fall from diazepam and also omeprazole showing the risk of fracture, you see the patient is more susceptible to developing greater problems. So what could be done or what was done there? We switched from atenolol to amlodipine, better tolerated in adults. That's why we say. But then amlodipine also comes with a lot of pedal edema, is what's seen very frequently. What did we do? We replaced the oral diclofenac with paracetamol or topical NSAID to reduce systemic effects. We already know the patient is renally compromised, so I cannot continue the therapy. Gradually taper down the dose of diazepam. It's just that we know that benzodiazepine do not follow the regular sort of tapering down. So you start from 50, 25, 75, 50, 25, and gradually take it down because people are dependent on this drug to have a sustained sleep. Okay. Now, what was done? Review continued. Need for then what they basically did was this was considered that omeprazole could be avoided, but then because it's an essential component here, we tried and removed things that are more difficult to be treated with. That is diazepam. We already saw that there was a risk of fall, so that is tapered gradually. So omeprazole could be continued because he is taking drugs again that are that could possibly lead to a bleed. Now, what do you see in the near future that can happen? A whole lot of it has got to do with pharmacogenomics. So basically, what we discussed that metabolism slows down, but the enzymes are still present. So how about I find out the culprit ones that are there and maybe taper the dose accordingly? Well, that comes with a lot of expense as well. Now, the next thing is telepharmacy, very frequently seen in various countries across the globe, and it's also planned to be introduced in India as well, particularly for elderlies. So what they do is remote monitoring of medications, whether they have taken it on time, you call them and you ask them and find it out. Another important thing is use of smart devices. This is a very niche area to work on, I must say, medical devices, very particularly, because this would help you to detect the minuscule amount of problems that are pertaining to a patient very easily and with a very short period of time. Medication adherence can be checked. Vital monitorings, vitals monitorings and things like that can also be seen. So someone, let's say, has a skyrocketing BP or BP shoot is there. So with this, you can come to know those things. Again, AI-driven tools. So basically what we do is we feed some data to the AI model and it predicts what's the risk with this particular medicine or this particular approach. What can be the alternate cause? Now, all of this clubbed together, what you would see is policy development. I developed this can be used instead of that, so and so, and forth. What could be the impact of this? By 2030, personalized medicine approach may reduce adverse event by up to 35%. So basically, it's that I am going to be improving the patient healthcare quality, healthcare services quality, and at the same time reducing the drug events that one might expect. Okay. Now, an important part of it is, again, as we say, nothing comes for free. So cost is there. So what do we do? They say that each $1 invested in clinical pharmacy technology returns $4.81 prevented in hospitalization. So for let's talk about if it's in INR, 1 Indian rupee, 5 Indian rupees can be saved for treating that disease. So it's a huge difference, you see, to help a patient. Now, what do we take away from this session? I believe you would be able to understand by now that definitely elderly people are a unique population. Polypharmacy risk is definitely with them. What I need to do is I need to use the right tool and also practice de-prescribing if necessary with scientific rationale to it. How me and you as clinical pharmacists can contribute. And at the end, what's the ultimate goal? I want to improve the quality of life, not just extend life or not just promote longevity. Now, just for some brainstorming, this is a quick question that I have for you. That is, I'm just going to read out that question. Mrs. Chen is an 82-year-old and has hypertension, osteoarthritis, recent episode of dizziness, and falls, and her current medications include amlodipine, diclofenac, diphenhydramine, metformin, aspirin. Her blood pressure is well controlled, but her GFR is 45 ml per minute. Now, which medication would you consider stopping first? If you could answer that either by raising your hands or unmuting yourself, or you can put it up in the chat box.
Sir, diclofenac, 50 mg.
Okay. Any other
Uh,
answers?
can be given topically.
Okay. Any other answers? Do we have responses on the chat? If someone can help me with that, what are the answer that they have?
Yes, sir. Ashwari is saying aspirin.
Okay, aspirin. Then you have some other answers? I'll wait. Or if someone has a logical explanation to give behind it, uh, they might unmute and come back with an answer. Is there anyone who thinks something else could be given?
Sir, from that recent episodes of dizziness and falls, then diphenylhydramine, 25 mg.
Okay. Who is that? Can you please tell me your name?
Anand,
Anand. Yeah, well, Anand is correct. The reason why we said it's very correct, you have made a solid point right there. That is, we see the past history of dizziness and fall. Now let's go back, and I told you that you might have to remember certain things correctly. If you go back of what was discussed, you see right here, we have already discussed the risk of falls are higher with certain drugs. Okay, and also over here, I had discussed the same component multiple times in the Beers criteria as well. So we see very clearly here, diphenhydramine is a drug that could possibly cause a lot of falls. That is, this is here also. And if you see here as well, you can see that the number of, sorry, just give me a minute. The risk with of falls is much more higher with anticholinergics. That's the reason why we were stopped at first stop diphenhydramine because the patient is already significantly at the risk of having falls. Now, there is this concept that we call as anticholinergic burden, ACB. And ACB is the number of anticholinergics that we have, the risk of falls increases. Okay, that's why anticholinergics are often given with good consideration before initiating that on someone new. Now, what else do you think can be removed from this therapy, or what else would you like to change?
sir, can I have one question, sir?
Yes, yes, please, please.
Uh, sir, what about diclo?
Diclofenac, why are we continuing it here is because if you see the previous case where we had given diclofenac, the intensity at which it was given thrice daily. Okay. So what we have done here is diclo, why it's given exactly here is to have osteoarthritis. Now that's the second priority that might change. The first priority would be diphenhydramine. Followed by that, you can gradually switch to diclofenac. But why we can continue on diclofenac here is because of the fact the patient does not essentially complain about GI bleed. That is one thing. Okay. And the second thing is that her GFR is although low, but she's still functioning normally. Her BP is well controlled. So the end organ damage is significantly lower to the patient. These are two reasons why this would suffice for now. Does that answer your question?
Yes, sir. Though depends on the patient's response when
Yes.
talking with them.
Yes, most definitely. That would depend on the patient's response as well, how well they are able to tolerate it, or maybe we'll have to look for evidences if there are any bleeds or if their GFR levels are going deteriorating further down. That could be another reason. So first priority would be to stop diphenhydramine. Followed by that, we can also switch diclofenac or gradually taper it down. Can be taken off, would not be a problem, and actually, as suggested before, can be given as a topical agent too. That would work well to prevent systemic problems. Now, since there is BP that's well controlled, that would not be a major problem because with increase of blood pressure, we see end organ damages are much more higher. Now, with that, I come to the end of my session, and I'd like to thank the entire organizing team for such a wonderful opportunity that I've given, and all the attendees for their participation and engagement throughout the session. I've given my contacts here. If anyone of you would like to reach out to me, you can reach out to me through my email or through my WhatsApp number that's active here. Or if you have any doubts, you can please reach out to me. Thank you so much and have a wonderful day ahead. If you have any questions, you're more than welcome to ask them now. Thank you so much.
Thank you so much, sir. So, Gargi Deshpande is asking, what is the use of aspirin in this patient?
In this particular patient, what's the use of aspirin? Okay, so okay, let's see what Gagi Pandey has to say about it, and then I'll come to the answer. Gagi, you have an answer? Or what made you think that why exactly would aspirin be, or why exactly aspirin would not be of use? She here, if you can unmute yourself. That's a very interesting question to begin with. And yes, there is some,
Sir,
what do you
can
say? Sorry?
Sir, aspirin 81 mg should be given in the patients who are having clots, right?
Yes.
And this patient, I don't think she is having any history of clots or something like that, or any stroke related issue.
Yes. Now, a very good point. Kudos to what you have thought just now, because that's another potentially inappropriate medicine that can be given. But it can be given as a prophylactic, but given the chances of having ulcerations, we might have to remove it. That's and I was waiting for someone to come up with that answer. Good work done on that, Gargi. Very good work done on that. That's a very valid point. It's a very valid point. Her BP is under control. So then, and her lipid profiles are not mentioned here. So very well done. Very well done. I was thinking that someone would come up with that question. Any other questions that they have? Anyone else would like to have a question?
Yes, sir. Thabasam is asking, is it essential to give H2 receptor antagonist or PPI when aspirin is given for ulcer prophylaxis?
Uh, well, aspirin could not exactly be given for as ulcer prophylaxis. Basically, aspirin in itself could be a very strong culprit to causing an ulcer. Okay, why do we need in this particular case? Why do we have to have a PPI or a H2 receptor antagonist very specifically? Is for one reason, that is you are on polypharmacy, multiple drugs. So you have to keep your GI, what do you say, the GI physiology intact, and that can only be, or the ulcer protection, future chances of ulcers can only be prevented by using of these particular PPI or H2 receptor antagonist per se. Does that answer her question? I believe. Avasam, does that answer your question? I hope so. I don't know whether she's here right now.
Sir, one
Yeah.
question regarding this. As
Yes.
firstly I said, diclo should be firstly stopped.
Yes.
Because I was thinking that aspirin may cause diclone aspirin may cause same like salicylate derivatives, no,
Yes.
that
Yes.
NSAIDs, huh? That's why. When but secondly, I thought of that aspirin may be used for secondary prevention
So,
of
can you
that
repeat it?
uh,
Can be used for?
secondary prevention like
Yes.
heart
Yeah.
strokes.
Correct.
Yes.
Yes. Yes. Because the patient is already having conditions that can cause it makes her susceptible to stroke. So then can be given as a secondary prevention, most definitely. But then that would again depend on the lipid profiles and other things of the patient as well. You see, because we have to take all of this from the background. So I've given you a very, what do you say, a very, let's say, a very easy and at the same time a very non-descriptive case to sort of heighten your what do you say, logical thinking to come up with answers. What might you find wrong in the therapy? So that's, yeah, okay, yes, again another good observation. Good to know that you are looking forward in that sense. Very well, very well. Yeah,
Sir Kiruba Kumar is asking, what purpose of metformin is prescribed here? She did not have any history of DM is not mentioned.
so you see now people are waking up. A lot of things are wrong here. Eventually, so you see that very few drugs. So you see, that's why I asked what was the question that was asked at first. The question that I asked you was, which one would you consider stopping first? That was the question. Okay. So the first choice was obviously the risk of fall is already existing in the patient. So what we did take out the risk of falls by removing anticholinergics. And then gradually, if you see, everything that is within the what do you say, the treatment plan, you'll have to reconsider the option. Why this? Why that? Another good observation, because I have not mentioned whether the patient has diabetes or whether the patient has any other comorbid condition. Who was it? Kiran. What was the name? I forgot.
Kiruba Kumar.
Kiruba Kumar. I'm sorry. Good observation. Good observation. So yes, very strong. Good to know that your minds are working towards the correct answers. Very good. Very good. Thank you so much. I believe that would be it. If there are any more questions, please feel free to reach out to me through my email. I believe the next session is about to begin. Thank you so much for the opportunity. Have a wonderful day ahead. Once again, happy Independence Day, guys. Thank you.
Thank you so much, sir, for that comprehensive and insightful session on geriatric clinical pharmacy. Your expertise and practical strategies have